All right, well, as everybody is taking their seats, I might get started. Welcome, everybody. My name is Brendan Crabb. I'm the Director of the Burnett Institute, based here in Melbourne, and the Chair of the Australian Global Health Alliance and the Pacific Friends of Global Health. And thank you to so many of my colleagues from Burnett and from those two peak bodies for your help in getting this session together today, particularly to you, Suman. Can I begin by acknowledging the traditional owners of the land that we're on, the land of the Wurundjeri people of the Kulin Nation, pay my respects to their elders, past and present. And in thinking about today's topic, possibly isn't going to get a major mention, but from an Australian perspective, at least, we can learn a lot from the success, extraordinary success of our Aboriginal and Torres Strait Islander people in this country over 60,000 plus years, which we've largely ignored in preparing for any health issue, in fact, let alone the next pandemic. I'm going to acknowledge the panel as I ask them to speak, but wow, we have an extraordinary panel this morning. Thank you all for agreeing to speak with us today. They'll get a chance to speak, then they'll get a chance to answer questions, and then and from me and also from all of you. So it's a big task to take on this topic. Are we ready for the next pandemic? We have an hour and a half to talk about it. I suspect there's a one-word answer if we were pressed. But of course that's not very helpful in the very real prospect of us facing the next pandemic. My background is I'm a virologist, and then later in work life became a parasitologist, but I'm interested in infectious disease and the molecular basis of infectious diseases. I literally teach pandemics. I did it yesterday at Melbourne Uni that I've done for a long time when I was a full-time university lecturer. Actually, pandemic flu's what's driven a lot of our concerns about what's coming next, and the H5N1 story is not panic stations, but it's very concerning, and it's a surprise to me that it's got to this point, frankly. This question of this session is one, though, that pre-COVID we used to have a lot. Are we ready for the next pandemic and so on? And of course there's a big theoretical elements to that. We've had near misses and so on over time. Of course it's not theoretical anymore. We've just lived through one. In fact, we're still technically in one, according to WHO. Clearly not in the emergency phase, but we're clearly in one 4 years later. Very hard to estimate, but there's every chance that the JN1 wave over this year's December, January, February period was likely to be the second largest number of infections since Omicron first arose at the end of 2021. So there's still an awful lot of virus around, an awful lot of impact of that virus around. So when thinking about the next pandemic, we've clearly got to learn the lessons of this one, and that's why we've structured this panel into two slightly artificial bits, but it gives some structure. We're going to talk about what happened in the pandemic, and we're going to talk about how those lessons might be applied to the next one in a structured way, and then we'll try to bring those elements together. Perhaps a good way to frame this is when we say, what are we ready, are we ready for the next pandemic, is to achieve what? What's the strategic objective? And I think it's worth dwelling on that for a little bit. Conceptually, I think we want to achieve, firstly, we don't want to see the pandemic in the first place. So for those who are in the session this morning, Esperanza talked about getting the basics right, I think was her literal phrase. And if you get the basics right, that means equitable access to good healthcare and a big focus on prevention of vector-borne diseases, of bloodborne viruses and infections more generally, of respiratory infections, and particularly now we're getting over this hump of how airborne transmissions, viruses are transmitted and so on. Getting those basics right, hopefully will see us a lot of the time not see anything take off in the first place. I'm sure that happens already, actually, to a degree. You don't know what you're missing. And of course, we want to be as passively ready as we can. And in that session, there was a lot of talk in that geopolitics session from Helen and Esperanza and Zor about that, actually. This session, we're going to, though, focus on effectively assuming something does get going again. And we've had quite a few near misses, and we've had, of course, the big one of COVID. And what's the objective if something does get going? Well, it's to obviously have a low health impact, and a low disruption at the same time. That's the holy grail outcome, strategic objective. Now, that, of course, quantifying what low health impact and quantifying what low disruption is very important. But conceptually, that's what we're after, both, not one or the other. You'll see a lot of discussion along the lines of, well, we can't do X next time because it's too disruptive, without saying what you're really saying is we're going to have much worse health as a result. We want both. So how can we achieve both? And what happened with COVID-19? Well, what happened with COVID-19 was, of course, really bad health outcome. Actually could have been even worse. But, you know, in the order of 30 million extra people died than otherwise would have died as a result of the pandemic. Still at the rate of about 3 million excess deaths a year. How many of those are COVID or not is unclear, possibly the majority of them. So still a very significant issue. And as I say, it's ongoing, a huge chronic burden that we're just starting to understand. So the health impacts have been phenomenal directly, and then, as Helen spoke about a lot earlier today, indirectly, enormous, the tail that you spoke about, enormous. So there's no question about that. The disruption was phenomenal. I think we're all in, if you're anything like me, we're still in a sense of kind of can't even go there. It was so significant. And even that's from our own, in my case, quite privileged context. What about in the context where life was so much tougher? The disruption was absolutely phenomenal. Of course, to normal life and the way societies functioned, to the way health services and education were delivered, to the way people could work and live in their normal way and look after themselves and their families, to economies and to our systems of operating. You know, we're talking about the biggest disruption since the Second World War in that sense. So clearly, we don't want that again. We don't want the health issues, we don't want the disruption. So what went wrong and what went right? You know, so that's what we're going to cover a little bit here today. I might just start in my 1 or 2 minutes left to précis some of those things. It wasn't all wrong. Clearly, the overall response was a failure. And we need to learn those lessons so that when faced with it, which we most certainly will be, and maybe very soon again, we don't end up in that position. There were some phenomenal wins, and we're in a position now when the next one does happen where our mindset's completely different. The first is in the area of vaccine development, which I can't believe what happened. The success story of the vaccines, which is my field of interest, to have effective vaccines within a year. I don't know that there's anyone who credibly would have said that. 3 to 5 years in an accelerated form is about the most optimistic I would have been. So incredible success story. That's changed our paradigm shift of how quickly we can get tools, potentially, course not. We're lucky in a way that this particular virus was amenable to vaccination. A little bit lucky, but that was phenomenal. And I think technologically in lots of other areas, testing's another one. We've just conceptually moved so far forward. Personalised testing, community-based testing that we don't just rely on a government service for. And through those things, I think just our thinking around technological solutions and how they can be available and personalised is completely changed. I think, and Rolf's going to speak about it a bit, I think data has been just phenomenal. Jody might speak about it and Alan too. And there's some good sides to that because there's a lot of sides we want to learn from sharing of data and doing it better next time. But I think the epi side, especially with certain countries as exemplars and certain regions as exemplars, was just phenomenal. But on the negative, you'll hear about speed or lack thereof, the slowness of the response, the deep underlying unfairness and inequity of the response, which is wrong and also, it's immoral, it's unethical, but it's also such an own goal. You can't deal with a pandemic if you leave someone behind. That's where it's just adding fuel to the fire. It's been crazy for any country to be comfortable with a parochial approach. Yes, that's what we had, deeply inequitable approach. You'll hear, I'm sure, much more about that. And I think there's some other issues that are less talked about. One that's close to my heart because of my background as a virologist and a molecular virologist interested in pathogenesis is that I think we have a big ego when it comes to the properties of the virus itself. The notion that a week or 2 or 3 weeks into the pandemic, there was serious consideration of letting a virus we knew nothing about and had never seen before go through large swathes of the population is absurd. It's absurd. But that is actually what won the day to a large extent. This is pre-vaccine and a different argument post-vaccine. But pre-vaccine, and as things have turned out, we didn't know that it could be a chronic virus and would constantly be a chronic virus, and it turns out it is. We didn't know it would evolve the way it has, the speed with which it has, the way it would do so in a chronically infected person, which is the most likely way we get these radically different variants. That ego got in the way of a quick response. We're very confident, and when I say we, I mean we, virologists, too confident about our knowledge of the way new pathogens might play out. And that gets in the way of you'll hear the word precautionary principle a lot. It gets in the way of that. The whole basis of that is we don't know how it's going to play out, so we're not going to take any chances. But we took enormous chances. And it played out very badly. Actually, we got a bit lucky as well. But that also might come out. COVID, in my view, is the Goldilocks virus. It's one of the reasons, perhaps, for the slowness of the response. So we have some good things that happened. Overall, it failed, and there's some big reasons why it failed. And we're going to focus in this session really specifically on understanding those specific things, where the lowest hanging fruit might be in change, where we can be passively ready as well as actively ready, where we're reliant on big global agreements and where we don't have to be reliant on big global agreements, all of which must come together. So with that, I am going to introduce our first speaker, and we will hear 5 or so minutes from each of our speakers, and then go into question time as we explore this topic a little bit further. I'm going to start with you Arabella, Dr. Arabella Colowan. She's the Director of Clinical Services at St John's Ambulance in PNG. It's a fantastic uniform. She's an emergency physician that practices in Hela Province and serving some of PNG's remote communities. That's just the start, though. What Arabella is herself and what she represents is what happened at the front line. And this is a story that played out in high-income countries, but it played out in spades in countries without the resources. Arabella and all her colleagues were thrown in the deep end with very few resources, very little up-to-date knowledge of what was going on, very poor PPE, and they were quite literally in harm's way themselves. Literally, before we're talking about the people that they were trying to support. I won't go through her extraordinary achievements in that front, but she was one of very few people in PNG who kept it all together and provided so much care and support for people in both the towns and in rural settings in PNG. Arabella, sorry, I got my notes. Over to you to tell us in your own words for a few minutes how that happened for you, and then I ask the audience to think about this played out in various ways, sort of a million times throughout the world.
Thank you very much, Brendan. And thank you for the opportunity to be here today to speak about a PNG perspective on responding to the COVID-19 pandemic. It's truly humbling to be on a panel of such esteemed people in the public health space. During the COVID-19 pandemic, I practiced at several different healthcare settings in a large, busy urban emergency department, in a field hospital in the country's capital, Port Moresby, and in rural and remote PNG. Even prior to the COVID-19 pandemic, Papua New Guinea had many challenges in delivering healthcare. In terms of the region, we have the highest maternal and under 5 mortality rates. Immunization coverage is the poorest. In the last few years, it's plateaued at 60%. And we've seen a resurgence of illnesses such as polio and measles. The burden of infectious disease remains high, and we're seeing an increasing burden of non-communicable diseases. For a population of over 10 million people, health expenditure is a mere $55 per capita. At its baseline, our health system exists in a very fragile balance, with limited capacity to respond to the everyday healthcare needs of the communities we serve, let alone be responsive to a global public health emergency. It's not surprising then that in the face of the COVID-19 pandemic, our health system collapsed. Hindsight is always 20/20. In the wake of the pandemic, we have many important lessons that were probably shared across many low-income countries. It's clear now that what happens very early on in the pandemic will affect outcomes for people all over the globe. Some of the important challenges that we faced included things like low health literacy amongst our communities. Public health messaging was ineffective in the beginning and poorly understood by people who had a baseline of low health literacy. Critical information about the COVID-19 virus and the important measures that were necessary to stop its spread not only didn't reach the communities, but didn't resonate with communities, especially those that were most vulnerable, where people were living hand to mouth. Not being able to leave your home during the day could mean the difference between having food on the table in the evening. In Papua New Guinea, and I imagine the same is the case for many low-income settings, public health mechanisms for surveillance were very weak. Before rapid antigen testing, access to PCR testing was limited, and turnaround times for COVID-19 tests were excessive. We didn't have the testing infrastructure, and access to PCR cartridges was limited. So effective surveillance was almost impossible. Essential supplies of countermeasures to reduce the spread of COVID-19, essential things for delivering healthcare such as PPE, vaccines, access to rapid antigen testing when they were developed, was slow to be distributed, leaving many frontline healthcare workers and at-risk populations unprotected and vulnerable. Misinformation presented a real challenge. Misinformation about the virus proliferated, outpacing accurate public health communications. This misinformation sowed confusion and mistrust amongst the public, particularly where sensationalist narratives found fertile ground in communities that were already anxious and already underserved by a poor health system. Aid, and I'm sorry, I don't mean to offend anybody in the room, but aid at certain points did also present something of a barrier. We really could not have mounted a COVID-19 response without the generous support of partners, but some decision-making around how aid was delivered seemed poorly considered and inappropriate for the healthcare setting that we practiced in. We received a large donation of ventilators, for example, and with a plan to send ventilators out to each province, many of which did not have the capacity or the healthcare workforce to deliver an intensive care type service. Where I practiced in rural PNG, it took 2 days to get oxygen, and we had limited access to more simple oxygen delivery devices such as nasal cannula or face mask, oxygen face mask. As we reflect on the challenges that we faced, it's important that lessons from the COVID-19 pandemic don't go unheeded. Each country remains culpable for strengthening their own capacity to respond to public health emergencies, but a low-income setting like PNG has no choice but to be reliant on collaboration and partnership and aid from more well-resourced countries around the region. We need better frameworks for more equitable distribution of health resources. It's come up multiple times during the conference, the inequities that existed and left low-income countries more at risk. We need robust strategies to combat misinformation. We need to support organizations such as the WHO as a voice for everybody. We need to establish rapid and effective and efficient communication channels to ensure that accurate health and care information reaches frontline providers. And we need to continue to foster collaboration As we saw through the COVID-19 pandemic, health crises are not confined to borders, but affect us all, and our responses should cross borders also. Thank you very much.
Thank you. Thank you so much, Dr. Colowan. You've given us a lot to think about, and I will come back about a number of things, but I probably will come back and ask you specifically about the misinformation issue as well. But thank you so much for that. To our next speaker, Alan Cheng. Alan is the Director of Monash Infectious Diseases here in Melbourne. He's an infectious diseases physician, and much more in Australia. He was a key person in the COVID-19 response. Nationally, through a number of roles, but also most specifically here in this state in Victoria, that had the toughest time by far of all the states in the pandemic. And Alan was very much in the eye of that storm as the Deputy Chief Health Officer in Victoria. And Alan, firstly, because I'm close enough to it, thank you for your service in that time. It was an extraordinary daily, early morning to late night for such a long time. Thank you for what you did for this community. Those who don't know, Australia largely lived COVID-free for 2 years. And the weak point of that was here in Victoria, and Alan and the team largely saved the day, from my perspective. So, Alan, the first 100 days in Australia, and you know a little bit more about the context of what I've just been saying. Appreciate your reflections on that.
Yeah, thanks, Brendan, and thanks for those very kind words. So I think all the Victorians in the room will know this very intimately, but obviously not everyone's here from Victoria. So I'll just have the next slide. So we had the two big waves in 2020, that tiny little one at the start, and then the much larger one, which even by today's standards would seem quite quaint, but you know, as you may remember, we were having 600, 700 cases a day at the peak. The first so this slide basically shows that, you know, how small the first wave actually was, and if just advance to slide one. This is just a subset of that first wave. You can see at the bottom there that 60% of cases were imported, and also that there were a lot of decisions being made. So all those little lines there you obviously can't read, but they were all the various decisions that were made from public health about shutting borders and internal controls and so on. Just the next slide is the sort of perhaps a way you haven't looked at this before. So these are panels showing the socioeconomic strata for each of the phases in this first wave. So the top left is basically the first wave. The top right is that intermediate period between the first and second waves, and then the bottom left is the large second wave. And what you can see there, the yellow is the most advantaged populations, blue is the most disadvantaged populations, and then this is by age group with youngest age at the bottom and oldest age at the top. So what you can see in the first wave is that this was a disease mainly imported, mainly people that could travel, mostly advantaged populations. There was this shift towards younger populations and less advantaged people, and then in the large second wave, it predominantly affected less advantaged groups there. So, and these numbers may seem quaint by today's standards, but 12% of people were hospitalised, 1 in 8 people were hospitalised, and 1 in 30 people died. So it was still quite a large impact on the community. The main early decisions were about, particularly very early on, were about when to shut borders and internal public health measures. And the major challenges were with communications with the public. Everyone was clearly anxious, and there was all the, people manifest anxiety in all sorts of different ways. And then also preparing the health system, given what we knew was happening in New York and Italy and elsewhere. Very early on, public opinion was largely on our side. There was all this following the science, which sort of got a bit trite in the end, but there was a sense that people were asking what to do rather than telling us what to do. But there was a lot of swirl of, good ideas, bad ideas, good analysis, bad analysis, and information. And it was quite hard early to sort out sort of sensible from sort of thought bubbles that people were having. What we did learn from our region was that, remember early on we were talking about bending the curve and trying to sort of salvage the healthcare system. But what a lot of Asian countries particularly could show us that it was possible to suppress the virus, and obviously that's what we did in March. But it worked the first time, it sort of worked the second time, and then the third time in 2021, it didn't quite work so well. And so we did need to adapt to these changing circumstances in the face of very shaky evidence. And then obviously there was the issue with maintaining social licence and cohesion, which became more and more difficult as time went on. So what did we learn? We could have done better with engaging communities. Very early on, there was the enforcement approach that obviously didn't work very well. The later responses towards the second half of 2020 were much more supportive. How do we get people to isolate and do the right thing? The notable exception was with First Nations people, and surprisingly asking them, how they should, take the lead and what they should do worked out quite well for the first couple of years. There were a lot of supply shocks. You may not know that all the N90 or a lot of the N95 masks in the world were made in Wuhan, and a lot of the swabs were made in northern Italy, where obviously there was lots of issues getting things out of both of those places. We had all the issues with test capacity. Some of these issues could have been anticipated, some of them probably not. There was the need for information. Getting situational awareness, even within Victoria, was obviously, elsewhere in Australia is already difficult, and then, what we're hearing from other countries is even more difficult. This became a particular issue when considering vaccine adverse events. We knew that they had occurred, but what rate, how severe, with AstraZeneca vaccine, for example. For surveillance, we eventually had quite a good surveillance system. We had, we knew sort of mostly how much infections, hospitalisations, we had genomic surveillance, wastewater, vaccine safety surveillance, behavioural and social data, and then obviously that got shut down over time. There was this tension between standardising responses across the different jurisdictions, but then also maintaining the importance of context. So things that would work or might be appropriate in Melbourne would not be for Darwin or elsewhere. And that adaptation to context is always important, but obviously it did risk confusing the public. And there was this fracturing of solidarity just, within Australia, let alone internationally. And I think there was difficulties in that messaging, in explaining how things were changing, so that, in 2020 and 2021, there was a lot of messaging, and there was very, fear about, how bad this virus was. And then 2022, everyone got whiplash trying to explain that, the population is largely protected, and Omicron was a slightly different virus. So I might leave it there. I guess there was probably just two things I might take issue that I think that I think it'd be very hard to say that the global response was successful, and particularly hearing Bella's narrative of what happened in Papua New Guinea. But in Australia, our overall strategy to minimise transmission as much as we could until the population was substantially protected by vaccine was largely successful, partly by luck and partly by design. But you can't hold back the tide forever. And I guess the other issue to take issue with is the precautionary principle can really, I remember talking to an ethicist early, it really can be used to justify anything. You could, we wouldn't have a vaccine program if people were too scared to have, if we're trying to take precautions not to have any vaccine side effects, or you might have to go and find the, flying spaghetti monster to address COVID. So it is a very slippery principle, and I think it is somewhat problematic to define. But I might leave it there. Thanks.
No, thanks so much, Helen. We can definitely debate the precautionary principle because I most certainly agree. You've got to progress. You've absolutely got to progress. But I don't think those two things need to be mutually exclusive. And thanks for reminding me. I meant to mention it early. I think we failed as a world. We definitely did not fail in each and every country. We're going to hear about another success story, New Zealand, in a moment. So much of this region, I think, having faced other challenges, particularly SARS, did incredibly well. And there are lessons from those successes that I meant to emphasise in my introduction. So thanks very much for reminding me of that. And now to the Right Honourable Helen Clark. Helen does need no introduction to this audience, partly because she's been introduced about 5 times already during this meeting. But of course, Helen was the former Prime Minister of New Zealand, has had many roles since in helping guide the world through humanitarian and associated issues at the moment on several fronts, but particularly through her work with the elders. Helen, we just heard you speak. Most people in here on the 3 Cs, but honing specifically in on COVID and your work with the independent panel, that was kind of reporting just after the eye of the storm, so not in sort of deep reflective time, perhaps as much as we are now. I wonder if you can focus a bit on the findings of the independent panel and the context around that. Welcome and thank you.
Well, thank you, Brendan. Good morning, everyone. The World Health Assembly meeting in May 2020 decided it wanted a comprehensive, impartial and independent review of how the COVID pandemic had been managed. And I really think that when they passed that resolution and told us to get a report back by May 2021, they thought it would be done and dusted. Instead, it was just gathering steam. Think of about the time we were finalising and presenting our report, the Delta outbreak in India was headlines, the most traumatic experience that India was going through then. So, of course, we were very conscious as we began our work, and I was appointed as a co-chair in July with Ellen Johnson-Sirleaf, and then our panel began meeting in September. But we knew that we were reporting as a pandemic was gathering steam, and that was a bit unnerving, and we ended up with a report where we made some recommendations about things that needed to be done immediately, but also whatever we'd learned about the things that needed to be done for the longer term. And as I recall, we did title the report, COVID, Make It the Last Pandemic. And that really speaks to your opening question, Brendan, which is what is the objective here? The objective is to stop a localised outbreak of a novel pathogen becoming a full-blown pandemic. Don't let it get legs. It's as simple as that. And what we charted with the work we did in the inquiry was how we just simply failed to do that. It could have been stopped at the first pass, but a lot of things went wrong. China wasn't transparent. That is a problem. If you're going to stop a pandemic in its ever developing, you have to have immediate notification. You have to share everything you know. You have to publish. You need full transparency. WHO needs tools to act. It needs to be able to go immediately to the site of an outbreak. It must be able to publish what it knows. It actually does need a precautionary principle. The IHR have been too skewed towards having to dot every I and cross every T before you do anything. But heavens, you could see what was happening in China. But somehow that wasn't enough to persuade an international health emergency committee from advising or recommending to Tedros that he call a pandemic, a public health emergency of international concern when he first convened the committee. So everything was going wrong in the first month. We could have stopped it in the first month if we replay the record and plug all those gaps. And I'm really hoping that the International Health Review exercise that our former Director General of Health, Ashley Bloomfield, is co-chairing, that they'll be able to nail some of these issues. But it will still need cooperation from countries. And if countries are hiding stuff, it's damn hard to get the speed of action that you need. So we certainly identified a lot of problems in that first month, just not able to get onto it quickly enough for a whole lot of reasons. But then our report was also pretty savage about the second month, because I think the world had got pretty complacent about public health emergencies of international concern, because for the most part, they were the dogs that never barked for most people. You know, we got ready for SARS. It certainly didn't bite us in New Zealand, Australia, most of the world. We hear about Zika. That didn't affect us either. Ebola was happening over there, didn't come here. The avian flus, didn't lead to the worst in most of our countries. So we kind of got used to these messages coming from Geneva, and the dog barked, but no one did anything much. This was different. That Tedros was there with his public health emergency of international concern on the 30th of January, and who did anything much? There was such complacency. New Zealand eventually had a response pretty like Victoria's, but if you go back and check the record, at the end of February in 2020, the New Zealand Ministry of Health put out a statement, and it said, "The first case of COVID-19 has been detected in New Zealand and is not expected to lead to any widespread community outbreak." Well, I can tell you within 3 weeks the system was in total panic. The smartest thing they did was throw out the flu pandemic plan, which wasn't relevant, and start to do a bespoke solution. But we were scrambling, like most countries were scrambling, because we didn't take seriously enough the public health emergency of international concern. So February was definitely a lost month. Now, what of course we were able to document was that most countries were pretty badly prepared for this. Obviously some honourable exceptions in East Asia, which had known pandemic threats and had to take them head on. So, you look at Korea, you look at Taiwan, you look at Singapore. I mean, there were countries a lot more ready to deal with this than we were, and most countries were. And one of the, I think, really important recommendations we made was that every country must review its experience with COVID and document it, because there's lessons to be learned from what you got right and what you got wrong. And the same in New Zealand. I think, like Victoria, all things considered, we had a reasonably successful response, but we didn't get everything right at all. And we need to learn from that, and we need to document it. Now, of course, there were inequities at every level of the response, and we'll find them in our own local responses and how communities were impacted. I think the inequitable way that the burden of COVID fell on our communities should be redoubling our resolve to address the social and commercial determinants of health, because those whose health was compromised by non-communicable diseases affecting heart, lungs and kidneys were extremely vulnerable and carried a higher death toll, as of course did the elderly. So there were those inequities in all our societies. But then the big global inequities, where the countries of the north basically hogged what was available, whether it was masks, oxygen, PPE, and eventually vaccines, diagnostics, treatments as well. This is really a shame on the human conscience, and it's not a shame that's going to be dealt with effectively in this first round of what comes out of Geneva and the Pandemic Accord negotiations, because people are in the trenches, and high-income countries like mine and those of most of you have been defending intellectual property rights in all their purity, and that doesn't help an effective response to a pandemic disease. We obviously identified needs in financing, the fact that many countries weren't prepared. Again, Arabella, you've spoken to the real challenges that PNG faces. If you're spending $55 a year on your health system, the chances of having a fully prepared capacity for a pandemic aren't great. We have to have solidarity to support the low and low middle income countries to be prepared. And that, we called for, as did the G20 panel, at least 10.5 billion per annum going into that solidarity funding. I think the pandemic fund, which was eventually established, has attracted something like $2 billion once, not every year. So that's not going to go very far in supporting countries to have the basic level of preparedness. And then if the pandemic threat materialises and you need to scale up very fast, you need something more like 100 billion to access, and no one has yet effectively grappled with how you would have surge finance to do that. It's something I would hope perhaps South Africa's G20 chairmanship might take up next year, because Cyril Ramaphosa has been a tremendous advocate for equity in action, and I think that could be helpful. We did recommend a new legal instrument in the form of a pandemic treaty framework convention, we said, which would plug gaps in the international legal framework. That's what's been being negotiated for some time. Funnily enough, having started off as a negotiation that looked like it was going to cover everything, it'll end up being more like a framework convention. But, you know, look, take it for what it is. You can build on framework conventions, as we know with the climate one. You know, it was a long way from 1992 and the Rio Earth Summit with the Framework Convention on Climate Change to where the world eventually got with the Paris Agreement in 2015. That's sort of the way of the world. Build on what you can get agreement on at the time. And as I say, the International Health Regulation Review is extremely important because it can do some very practical things. Interestingly, at the same time as our independent panel was meeting, so was the IHR Review Committee, the previous one. And they recommended no change. They said the rules were fine, but they hadn't been implemented. Well, that's all very well, but clearly you can't just leave it there. And we were haunted as a panel by listening to Gro Harlem Brundtland, who'd stared down the SARS pandemic when she was Director General. She told us if she had had to operate under the 2005 iteration of the International Health Regulation, she could not have dealt with SARS as effectively as she had some years before. So actually, the IHR of 2005 made things worse. And I'm really hoping that Ashley Bloomfield and his effort can make things a bit better again. So, you know, this was some of the helicopter view kind of findings that we came up with. We recommended clearly stronger base funding for the WHO. And many people aren't aware that the WHO has a budget about the size of a medium-sized New York hospital, and it's supposed to lead on global health. It is ridiculous. At the time of the pandemic, its base program was only 16% covered by member state core contributions. Ridiculous. We recommended that go to 2/3 and there be a replenishment for the other third. There was some good work led by a German diplomat who got an agreement to move it to 50% over an 8-year period, which is like forever. But at least it was some movement, and they're now moving on the investment case for the replenishment. So some action on that. Final point I'd make is we identified the lack of political leadership in fighting the pandemic. You know, everyone was looking after themselves, right? There was too little coordinated global leadership, which is why we recommended a Global Health Threats Council. We said this is a threat that no other leadership mechanism is dealing with, and that if you had a body of leaders drawn representatively from across the world's leaders who could keep an eye on the mobilising of preparedness and finance for preparedness and response and jollying everyone along, that would be a good thing, but that hasn't been able to get traction. We also recommended a high-level meeting in New York to give some momentum to processes, including in Geneva. That ended up being a wimp. Member states really didn't use it the way that they could have. But look, it is what it is. I think our report did get a lot of attention. I think it did cover all the key bases. It made practical recommendations. One way or another, you know, things stagger on and things will be better as a result, but it's an ongoing business. The job will not be done in Geneva this month or next. And just to answer one final question that's already come up, are we better off now to fight a pandemic or worse? You know, we're still fresh enough to take on board the lessons of what happened. The problem is we would try to fight another pandemic like COVID tomorrow with every country greatly fiscally weakened by COVID. We all borrowed far more than we were ever comfortable with to try and keep economies and societies going. And secondly, the loss of social licence for mobilising a public health response, I think, has been quite profound. We ended up with very fractured societies, people believing the most incredibly stupid things, and it just, how would we get that strong public health response again? That really worries me. Back to you, Brendan.
Thank you so much, Helen. And, interesting you mentioned Cyril Ramaphosa there, who, with inequity being at the heart of what's gone wrong, really. There's so many elements, but inequity as to how that plays out. And from my perspective, at least, he's articulated that in the strongest kind of jaw-dropping way on several occasions. But the determination with which low-income, low and middle-income countries feel to never go through that again is profoundly expressed by Cyril Ramaphosa. He said, "We felt like beggars," was his phrase, trying to get vaccines. And it had such cut through. So there's a force there that is very powerful and is going to play out significantly, I think, as we plan for the next pandemic. So to our last speaker in this first bit about reflections on COVID-19 pandemic, Rolf Apweiler, to talk a bit about the science. And Rolf is the director of EMBL EBI, which is the European Molecular Biology Laboratory. Very familiar to me, but we always call it EMBL. And I mentioned in my successes, and maybe it's also, I'm sure, room for improvement, was what happened with data and what could happen with data. Rolf comes as one of the most experienced and capable people with respect to data platforms, and played a very significant role around the European COVID-19 data platform. How are we all going to communicate and talk to each other? How are we going to get the latest information in real time, not 2 months later or 3 months later, to inform decisions? How did it work during the pandemic, and sort of what can we do next? Rolf, great to have you here.
Yeah, thank you very much. And of course, it's now a very hard act to follow after this stellar presentation, but I give my best. So I got involved into dealing with data around COVID because I was at this time already together with my friend and colleague Ewan Burney, the director of the European Bioinformatics Institute, which for you probably not aware of what we're doing. So we collect a lot of data on nucleotide sequences, proteins, protein structures, gene expression, and so on, in scientific literature. And then we put that into databases, work on the data, and give it back to the interested people, usually scientists, but also others. And to give you a sort of impression how much that is, every day we have around 100 million accesses to our websites, and in a year's time, around 40 million different IP addresses. So that is probably the largest provider of such public domain information, scientific domain information in the world. And since we collected already a lot of data, the European Commission contacted me in, I think, beginning of March 2020 and said, well, can you collect all data around COVID, bring it together in a platform for Europe and share it? And we said, well, that shouldn't be too much of a trouble in principle, because what was the interest of it? Of course, the nucleotide sequences for surveillance, but also for really understanding better the biology. When collecting also the host data, so it means not only humans, but also animals which are infected, for understanding better the interplay between host and the pathogen, and collecting information on medicinal chemistry of how certain compounds bind to potential targets. Again, all of these components we had already, and they were there. We thought then we only need to bring that all together, and good it is. So that was, technically, it was not really a problem. In 6 weeks or so, this was up and running. but there were really interesting lessons to be learned. So AMBL is an intergovernmental organization. Nearly all European countries are participating in that and governing that. Australia, for example, is an associate member of EMBL. And still, we had, on our government's board were ministerial representatives, but they came from the research end, and in some cases, even from the foreign minister, in the case of France, for example. And even if we try to reach through these channels into the governments to make sure that we can get the right people to talk to, that the data flows as quickly as possible, very often it didn't work. Where you had a really good connection between the health ministers and the research ministers, where they worked together, it worked very well. But where this wasn't the case, it took months, sometimes years, and sometimes even now the data is not flowing at the speed that you would expect. Having said that, it was still pretty successful, because as you know, we got quickly vaccines, we got quickly drug repurposing and so on. So there were success stories, but there are lessons to be learned that you really need to have a more coming together of different parts of governments. And that is not only important really in the context of pathogens. If you think about the value of genomic medicine also for the future of healthcare systems, then it's also very important that it's understood that it's not two silos. Here's the healthcare system, and here's the research system. The information which is generated or could be generated in the healthcare system can directly feed back into research and then speed up the development of new diagnostics and drugs. And in the case of a pandemic, this is of course of utmost importance that it's really going on speedy. And so if there's one lesson, then think more about teamwork and not about silos. And then I think technologically a lot is doable, but it's really the political will, the understanding that you need to work together, which is important. And there's one final point I also want to make. So a lot of data which was generated in the public health sector was paid for by the taxpayers with the purpose of giving information to the public as quickly as possible. Unfortunately, in a lot of countries, Western countries especially, a lot of the scientists who were running these public health efforts didn't see that as just as something which should go as quickly as possible. Very often they saw that also as the treasure trove for harvesting scientific information, and were not as open and quickly as you would expect. And I think this is a big disgrace. In the case of low and medium income countries, I have complete understanding that they want to have very often a tie between equity and access, yeah? But not if you are paid by the taxpayer to generate this data and give it as quickly as possible to the public. Then I think this is a complete misuse of your position. And this happens still in a lot of countries. And that's what really pisses me off. So with that, thank you very much.
Really pisses me off. Sorry, I'm just writing that down. Thanks, Rolf, very much. And so we could categorise the challenges that COVID-19 has thrown up. One of them, Rolf has just said, was a major conclusion of Helen's, is the need for political leadership, and we'll come to that. You know, it's an all-encompassing thing. My interest is, how do you mitigate against the reality that it'll never be perfect? You'll never have, 20 leaders in a room who all think in the appropriately community-centric and publicly spirited cooperative way. It doesn't work like that. So how do you mitigate against that is kind of a theme that I want to get to. But we're going to move to the remainder on our panel, but now speaking about preventing the next pandemic as a sort of starting point, although they're free to go wherever. We've got the speed issue, we've got the the inequity that I just spoke about, and the challenges and the successes. How can some of those lessons lead us to a better response next time in this very imperfect and messy world that we live in? I'd like to turn first to Jodie McVernon to talk about that. Jodie happens to be local from Melbourne as the head of epidemiology at the Doherty Institute, but wherever we were in the world, it'd be great to have Jodie be very early picked to be on a panel like this. She played in Australia a really significant role. She was the most prominent scientist in Australia during the COVID-19 pandemic, and she's got very strong global interests, as you'll hear in a moment. And I mentioned that Alan was absolutely key to how things played out, and certainly another of no more than 3 or 4 players that were crucial on the science side is very much Jodie. Jodie, with that background and your background that way predated the COVID-19 pandemic in this space, the lessons you learned through it, how can we do, and there are a lot of successes, but how can we do better? What's the route that you've come up with to especially detect what's going to happen sooner and respond faster?
Thanks, Brendan, for that
2
introduction.
words. No.
Yeah, I have 5 minutes, but I guess I'm dealing more broadly with the issue of how we do surveillance better, and I like 3 points and I like alliteration. So I'm going to talk about it being objective-oriented, it being One Health in its approach, and also how we optimise resources to best serve the public in response. So back to, and a lot of the things that I'm going to talk about have already come up through all of the speakers, so I guess I'm just going to draw them together in a different way and maybe add some slightly different angles to that. But in saying that, information is there for a purpose. It's there to actually help us make better decisions, to improve outcomes, to inform action. And throughout a pandemic, yes, we have an overarching objective, but there are many, many other objectives that are phase-specific as we move through different aspects of a response. So whether that be the ability to early detect a pathogen that may be of concern, whether we have then that early characterisation, how do we determine its likely transmissibility, its severity, the risk groups who are most likely to be impacted in terms of severe outcomes. As we work towards developing interventions, whether they be non-pharmaceutical or pharmaceutical, how do we know how they're being taken up in the population, and can we find evidence that they're actually being effective in achieving their goals? And then obviously as we're moving into recovery phases, how do we consolidate the safety of society? How do we deal with subsequent waves? How do we understand the magnitude? How do we look at the long tail effects? So there are lots of different information needs. So really identifying crisply and clearly the information needed to support those decisions is key, and things like WHO's Mosaic respiratory surveillance framework breaks us down into those parts of action and says, well, what's the information that can inform those things? So being really clear about why we collect information, but then also how we communicate that information to the people who make decisions. And they're not just politicians. Obviously, in rapidly evolving scenarios, we're having to synthesise complex information with high degrees of uncertainty. Getting better at communicating that message up to guide decision makers who need to take action is a very strongly important part of what we do. But also, how do we disseminate those forms of evidence out through different parts of the health system, through public health units, to communities and to the individuals who, at the end of the day, decide to cooperate with the recommended measures or not, and that is what leads to the outcome. It's not just about what we tell people to do. And so the development of trust and the development of effective communication strategies and the minimisation of infodemics and miscommunication is all part of that information loop. I've talked about a One Health approach. We had a great panel about that yesterday. It's really important in thinking about drivers and determinants of disease to think about, when and how infections emerge, cross-species interactions, drivers of environmental and climate impacts. And so bringing all of those sources of information together is important, but again, it's all about trust and shared governance to make sure that the forms of knowledge communicated are done so effectively in context, and that we can use our shared understanding of what that information means to understand, you know, how these different sectors and systems influence each other and lead to different impacts. It's also clear that the states of health and disease through pandemics are not just about infectious agents. We saw many other health conditions deteriorate in their outcomes due to impaired access to healthcare, lots of other non-communicable diseases and so on. So thinking about all of the system impacts in terms of health outcomes and well-being. Mental health impacts obviously were substantial, and at global level, you know, the Strategic and Technical Advisory Group on Infection Hazards includes now mental health expertise as one of the key areas that we need to consider. And obviously also the other societal impacts in that whole of society framing of One Health of an emerging infectious disease and the interventions for its control. All of these other economic and social impacts that we've seen through COVID are not just about the infection. So finding the right balance, finding the right measure, and, you know, this whole concept of proportionality. How do we minimise harm generally? We've seen how COVID has increased poverty, inequity, all of the other things that we've been trying to work towards reducing globally. And then just the optimising resources, as I say, information for action. The actions, the objectives are changing over time. I think one of the mistakes in COVID was the continued generation of knowledge well beyond its sell-by date. Did we need to keep PCR testing everybody as case numbers were escalating in Victoria? What was the opportunity cost of that as test capacity, you know, greatly, well, as requirement greatly exceeded capacity, you actually lost the public health impact of that piece of knowledge. How do we have the confidence to turn surveillance systems on and off and then say, all right, now it's time to stop doing that and move to something else, and be really clear with the public about why that's the case, and give them confidence that we're not abandoning them, but we're moving to the next thing that we need to do for them. Obviously, bringing that information together, having efficient forms of data linkage already in place, having the trust and the governance and the legal frameworks in place, bringing information together using modelling and other approaches to maximise the knowledge gain. At the time we get surveillance data, it's already old. How do you bring it together to do what we call nowcasting, to say, well, actually, this is where we are by now, and in the next couple of weeks, this is where it might go. How does that relate to sector capacity and resourcing? So those are really the three things: objectives, One Health, and optimisation. But I think, you know, we need to learn from what we did that worked and didn't, how to do those things better. Thank you.
Thank you so much, Jodie. Alliteration does help. I'll remember those 3 O's now. Thank you. And I'm going to move now to Professor Chang Chuan Chan. Professor Chan is from Taiwan. He's a distinguished professor at the Institute of Environmental and Occupational Health Sciences, College of Public Health at the National Taiwan University. He's a professor of Global Health Program at the College of Public Health at National Taiwan Uni. If I listed the involvement of Professor Chang in Taiwan's very successful response that's been referred to already, we would eat into a lot of our time. But it was remarkable, and I imagine based to some degree on lessons learned elsewhere. But to you, to perhaps capture that, but especially from those lessons learned, Professor Chan, you know, how can public health infrastructure, especially with a regional perspective, be improved?
Thank you. If we want to answer, can we prevent next pandemic? And I agree with Helen, you know, the mechanism not there to know from the beginning, then we can, you know, suppress it very quickly. So far, we don't have the information systems to know about that, even though we have scientific tools to do that, okay? And if we want to answer the questions, can we respond better to the next pandemic? And I would like to frame it into parameters. One is what outcomes we are talking about: lower death rate or lower infections, and the time frame is when. Back in this first week of December 2019, I hosted spectral lectures in Taipei, featuring the founding fathers of public health education, higher education in Taiwan. And my guest is Peter Piot, then Dean of London School of Hygiene. And his talk is, "Are we ready for next pandemic?" after 100 years of Spanish flu. And when we have this discussion, definitely not, right? But the time frame we had is probably years ahead. But we didn't know COVID is already happening, right? So the same things, are we ready for the next pandemic? Probably there's one ongoing somewhere, okay? So that's a lesson from Taiwan, because back in 2003, the SARS, Taiwan is one of the hard-hit countries. We took lessons hardly. We created Taiwan CDC. We reformed our laws. We improved infectious controls in hospitals. So all of this worked for the first half of COVID by just implementing these non-pharmaceutical interventions. We controlled it. So I thought it would be better when we are facing the uncertainty that we didn't know the origins and we didn't know quite well of the virus, then it's easier to harness the society consensus to do that. But after the Omicron, actually, we did not do well. We still record. We are about 30 deaths every week in Taiwan. You can see. So we have vaccines, but people don't want to be boosted. So all these kind of things of MPI, if we want to look at the supply chain of masks, gowns, testing kits, now probably our region is better off. We know how to locate them and how to distribute it, right? So this will be no problem if we want to do, but I don't think it's sufficient. In terms of our region, the vaccine availability from this region, is very bad and still a failure, right? If you look at stuff from Asian Pacific region, from Korea, Japan, down to the Australia, we all fail in developing vaccine that can support like hundreds, millions population in our region. That we have to strengthen, because science are there, manufacturing capacity are there, but we are not talking about this, and it's very dangerous for next pandemic. Yeah. And if I want to use Taiwan's lessons to say what should be done in our regions in the futures, as I mentioned, every country has to take the lesson hard. And don't wait for international agreements or regulations. As you know, Taiwan has a special status. We are not a member of WHO. But we observe WHO guidelines as a low bar. You have to do it, even though we have no right to sign it, but you follow it, right? But you have to strengthen based on your needs. And Taiwan is a disaster-prone area. So the society is more risk aversions, right? We need to be heedful for all kinds of man-made or natural disasters. I think this also very similar in our region. So we have to create this, and so every country has to do this. But I think just awareness of COVID has decreased significantly over the year because of other crises coming up, like climate, wars, etc. But this should be kept on the top priorities. And The other thing is, you know, regional cooperation is very important. You know, country in these areas always borrow measures or strategies from another country. Like we watch closely what Victoria is doing, what New Zealand is doing, and they are very good example to convince politicians say, doing this and doing that is right because a country or area like that is doing it. But actually we did not communicate, right? So how to create this kind of communication among the parties concerned, not just government, would be very useful. The other thing is private-public partnership. Throughout this pandemic, no government can claim they are victorious or successful, right? And in Taiwan's case, if we don't have like two big companies in Taiwan and the biggest Buddhist NGO jump in, we will not have machines ready for us. So because of them jump in to purchase, you know, to assist government to purchase machines, then we have sufficient amount to fend off Delta and then the Omicron. But it's too late, so that's why our casualties are high. So how can we do this? Try to, you know, let private sectors initiate, and government has kind of a mechanism to work together. I think it's also the spirit of our region. Our region is quite vitality in the economic activities. Lastly, we have to come back to review this MPI because MPI has a lot of public health achievement, but have political cost, has financial cost, and the biggest one is the cost in social trust. That's why we're seeing people are not doing screening and not boosted because the credibility of us convincing the general public has not evolved. So that's why people this is the origin of distrust in public health measures in our region. We have to deal with this. So I hope I give you some of the lessons from Taiwan, and I'm here to really like to call for cooperations of the regions, even though Geneva next month probably cannot come up with some global consensus. I think our region can start it, and Helen can start it. Say, let's work together, right? And at least on civil society level, say we have real exchange, sharing of information and data, and that would be very useful for us to really control the next pandemic. Thank you.
Thank you. Such a common theme, that one of trust, and I suspect we could have I really do suspect we could have easily had a whole session on that. So much is at the heart of what society will buy into, what they think about this, what they believe, what they will take up. From my own perspective, social science was the big side that was lacking in this whole response. It was almost completely absent, which is a lesson. Thank you so much, Dr. Chan. Our last speaker is Michael Baker, Professor Michael Baker from the Department of Public Health at the University of Otago in Wellington, in New Zealand. And Michael was an absolute, and his team, an absolutely instrumental figure in the idea of COVID elimination in those early days, that you could live without it at all while waiting for vaccination. And I learned a lot through Michael, who's very, in my view, ahead of his time, and how on earth you were so convincing, I don't know, but you made a very big impact on many of us around the world. As I guess reflecting a little bit on those days, but more looking forward, Michael, you know, what sort of would be the priorities for a public health strategy in the next pandemic, considering the sort of challenges we've just talked about? We can't just redo that one. Michael.
Well, kia ora everyone, and thanks Brendan for the introduction. I think it's very fitting that the World Health Summit is happening in the Asia Pacific region, because this is the part of the world that developed a new innovative approach to dealing with pandemics, and that's obviously disease elimination. Now, anyone who works in infectious diseases is very familiar with the concept of elimination. It's been around for decades. We have elimination strategies for all sorts of diseases like measles and polio, but the innovation here was using it for an airborne respiratory pandemic. And I think, like many people in the room, we're all relieved that we can now use the term airborne. It's been officially sanctioned as a term by the World Health Organization, recognizing something we've known for a very long time. And I guess my appeal is that we should rehabilitate the term elimination for pandemics in the same way. And you may have noticed that the World Health Organization will not use the word elimination and COVID-19 in the same sentence, which I think is remarkable. Even now, it's a bit like your former Prime Minister, Scott Morrison, who the word would not leave his lips, even while every state and territory in Australia was furiously pursuing elimination. And if we think globally at the moment, we are to some extent living in the spectre of a potential avian flu pandemic. Fortunately, there are still some biological reasons why it's not adapted to human transmission. It has obviously a very high case fatality risk, 50%. But even if it was only 2%, and that's the level of the 1918 flu pandemic, you can guarantee every country on earth would do everything it could to exclude it and eliminate it. And yet we don't have that in our vocabulary for discussing pandemics. How can we have a clear, coordinated response, which everyone in the panel is talking about, if we don't have shared structures and frameworks for talking about these things? So is the world ready for the next pandemic? Yes, but I think it's time to recognise one of the two great lessons from the pandemic. One was the rapid development of vaccines. The other is that basic public health and social measures can stop a pandemic in its tracks. And we need to have both of them. They're very complementary approaches. And we know with flu, there are stocks of vaccines available that could be scaled up to provide much of the world with an effective vaccine within 6 months. So that's another compelling reason why we need to use public health and social measures to complement these other huge advances in technology. And I'm still mystified why we're not embracing this kind of strategic thinking, because we have so much evidence that it works. And so I can't resist showing some slides, because I think the picture's also very compelling. I mean, this is infectious disease 101. We know that there's just 3 things you can do with an infectious disease. You can ignore it, which we do for many things, which is fine. We can control it, which is what we usually do, and usually we go straight through to suppressing it. Occasionally we have to resort to mitigation. That's really only in pandemics, when they risk overwhelming the health system because there are so many cases coming. And that's our traditional influenza plan. But we're also very familiar with elimination for endemic diseases, and occasionally global eradication, which of course we did achieve with SARS. So why not apply the same approach to pandemics? And people sometimes say, it's all very well for, and we have representatives from Australia, Taiwan and New Zealand. We're high-income island countries. We've got a natural advantage with elimination. It's easy for us. But look at the other countries that also successfully eliminated the pandemic for about 18 months. In our region, low-income countries with long, complex land borders. So there's no barrier to countries doing this if they have that strategic intent. And we published a paper in The Lancet at the start of last year saying, surely this is a time to build elimination into the international health regulations as a strategic framework. And we said, look, as soon as you get a public health emergency of international concern, because that's already reached a pretty high threshold of something that you don't tolerate. At that point, there's an obligation on the World Health Organization to assign a response strategy. It might be just to suppress it, but it could be to eliminate it within a region or countries or globally as the preferred strategy. And that would shift the IHR from what it is at the moment, largely a surveillance tool and reporting tool, to something that actually signalled a strategic direction, which I think would shift it into a really valuable response tool globally. And remember, the two things you want to do, you want to eliminate its source, preferably, and you want to shift the culture to elimination at source as the preferred approach, or slow its spread to give you time to learn more about it and develop vaccines. And we're all very familiar with this kind of 2x2 table looking at the quadrant of high transmissibility and high case fatality, and the usual villains are in that quadrant. Obviously, pandemic flu, smallpox if it was released again, disease X, and also synthetic bioweapons, which unfortunately are getting more likely. So we want to be able to respond to these threats rapidly and effectively. And so that's quite a long list there, but it's just saying we don't need to change the IHR very much to make it work. We just need to have in there the concept of elimination, the fact that it's linked to eliminating its source and slowing spread, and also that there's a requirement that if you have a public health emergency of international concern, you must assign a response strategy at that point. This is the emergency committee can do all of this. And another refinement is the ability to have predefined green zones to make it much easier to coordinate the business of slowing the virus down in the least disruptive possible way. And New Zealand had the experience of having a green zone with Australia during some of the pandemic, and it really was great. It really did reduce the disruption of those control measures. But just think, if we did this at a global level, coordinated by the World Health Organization, it would be so much more effective, less disruptive, and more equitable. So I still think tactics without strategy is a noise before defeat. I mean, it's an ancient term. It's from the management world. But if you think about it, it makes so much sense. How can you coordinate a whole lot of responses and particular interventions without having a coordinated strategy? So that's all I'm appealing for here. And I would love in the future a public health triumph, nothing happened. And that's surely the dream outcome, isn't it? Thanks.
Thank you, Michael. Now, conscious that we only have, I'm going to say 8 minutes left, even though it says 4 minutes left. We're not going to take audience questions. I am going to work my way through the panel for them to speak for 1 minute each on the notion of what does give you hope. And it's okay to say I don't have any hope. What does give you hope in a nutshell? I'm going to work back from Michael because I'm going to take you up on a point you just said. We'll come back this way, but skip over Helen, who will wrap up for us, especially speaking about the very pointy end of the accord and the IHR that we're on. But Michael, in you answering this question of what gives you hope, but also reflecting on what is it? Why is it that we can't use the word elimination? Not just the word, I guess, but everything that's behind that. And is there a way around that we can, we talk about it with TB, 2 billion people have that bacteria, and we can talk about elimination. We can talk about it with malaria, my own area of interest, with literally billions of people affected a year. What's the barrier?
Well, firstly, I think the good news is we're having the conversation. People know what a pandemic is. They know they don't want it to sweep through the globe, and I think they understand about equity. So I think we've all learned a huge amount. I just think we need to turn it into concrete action.
So it is possible. That's very hopeful. I like that. Jodie.
The thing that makes me hopeful is a renewed emphasis on data for decisions, and that's a global emphasis from WHO and downwards, but also the large global funders, Gates, Rockefeller, Wellcome, funding development of capacity to generate and use evidence effectively with a really strong focus on low middle income country settings, so that all countries can generate, access, synthesise, use their own information in their own context to guide their own decisions.
Thank you, Jodie. That's also very helpful and very doable. Professor Chan, so much in your presentation I'd like to ask you about. A pet area of interest of mine is regional cooperation, effectively, that you spoke of as a desired need. But your thoughts?
Yeah, I think I echoes Michael's talk on this. I think airborne should be educated throughout this, so we have to know to change the ventilation in our living environment. I think it's very important. Airborne should be in people's brain. This is very important. The second one, in the policy, put admissions possible. That's a lot of political decision has done said it's impossible, so we should put it. The last one is corporations. True cooperation, not between government, should be between academics and civil society, NGOs. I think that's, if we see these flourishes, we are better off, we will be more resilient for future shocks. Yeah.
Thank you, Professor Chan. And because I'm not going to get a 2 minutes sum up at the end, I was also going to emphasise being passively ready. If you've got clean water everywhere, and if you've got clean air, indoor air strategies everywhere, if you've got safe food everywhere, you're more than halfway there. And that can happen, not to mention if you add stronger health systems in low-income countries. You're doing a lot to be ready. So thank you for those comments. Arabella.
I think what makes me hopeful is that 3 years on, we're still talking about the COVID-19 pandemic, and there's so much emphasis being placed on learning lessons and not repeating mistakes, and just being better so that we make our health systems more resilient and more responsive to public health emergencies.
And do you think, Arabella, just because I'm going to take the chair's prerogative to ask another question, do you think there's a sense of that in PNG, with authorities, that this is a chance, or is it, I only go up periodically and I get a sense that was yesterday's problem and now we can move on? What's your sense of that?
It's really difficult to be still thinking about the pandemic when there are so many competing priorities for health at the moment. But the fact that people are still talking about it at a global level, I think will help us keep it at the back of our minds and make sure that we're taking measures to be more prepared.
Keep talking is a great message. Thank you so much. Alan.
I think Michael's already talked about the public health paradox, and I won't go there, but I think Esperanza this morning said she didn't need to educate people on the health consequences of government policy, and I'd add to that I don't have to explain the social determinants of health, which we all know, but clearly not everyone else does. So I think that was something that sort of, we can anticipate some of the issues that will be in the next pandemic earlier on, hopefully.
I agree with that. It's and it's also kind of the flip side to this mistrust, disinformation. We say we've got all sorts of problems with the community not engaging, but in another way, I mean, every Australian knows what an epidemiologist is, for example. It's a completely different world in understanding and readiness of people who don't live and breathe, no pun intended, this every day. You're absolutely quite right. And I think that does stand us in very, very good stead. Hopefully it will be another 100 years. Those lessons will be forgotten. But if it's not, as we all suspect, we will be in that position. Rolf.
Well, I think there are 4 things which make me fairly optimistic. The first thing is just a very technocratical point of view. Technologies get better and better. We have more possibilities to act. Oops. Even if gravity is still there. So the second thing is that I believe that education levels worldwide are increasing. That means we will have better abilities to fight mistrust, miscommunication, and so on. The third thing is that also, again, worldwide, at least more and more influential people understand that the world belongs together and that animal health, human health, changes in the environment, that this all needs to be looked at together and that there are challenges coming out there and we need to prepare for that. And the last point, I just forgot.
Never say four things.
Let me see whether I get back to that. And the last point is also that, and I think that's really the most important point, again, that more and more people understand in such cases, everyone on the planet is only safe, each one on this planet is only safe if everyone on this planet is safe. And that this silly behavior of it's mine and you are coming later, that this is just counterproductive. Even if it's a very human sort of behavior, it's irrational and counterproductive, and more people understand it and really fight it. And these 4 points make me pretty optimistic, even if I know there will be always bumps on the road, and it's not easy going. Thank you.
Thanks, Rob. And Helen, to sum us up and take us home.
I'm inclined to take a glass half full perspective, and let me make 3 points. Firstly, I think we will get improved international health regulations out of the negotiations. The text is now out. It has some improvements on notification and WHO's rights to investigate at the source of an outbreak. It also is proposing an early alert option prior to a full public health emergency declaration, which I think is useful, and it's attempting some definitions for pandemic and pandemic emergency. I feel that the world didn't really set up until Dr. Tedros used the pandemic word. To the general public of the world, public health emergency of international concern is kind of complicated, isn't it? But pandemic, my God, that people do, it does attract attention. So I welcome this going into the lexicon of the WHO, which it hasn't been, except for the rallying cry of March 2020. Secondly, on the negotiations around the pandemic accord, I am hopeful that there will be some kind of framework headline agreement to come out, and with a forward process to build on it over time. A process we're familiar with the Climate Change Convention. Also the Framework Convention on Tobacco Control didn't try to define everything at the outset. It was a framework. And then the third point I'd make is that, in a sense, and I think others have made it, we don't have to wait for agreements to get on with some stuff. And part of that is the need for an end-to-end countermeasures system. We need much greater diversification in R&D expertise and manufacturing to have scaled-up responses in pandemic emergencies. The WHO got it right in establishing that mRNA hub and spoke system. It needs to embrace more technologies, but in essence, the concept is make sure that in developing regions there is a good spread of institutions which are skilled R&D hubs and can quickly pivot when a new disease comes along that needs a solution. I mean, mRNA wasn't new, right? But it was tapped by those who had access to it. When the South African hub was denied access by Moderna to the technology, it quickly pivoted and retro-engineered it. So I have great faith that with actually not huge sums of investment, you could build a much better ecosystem of R&D around the world linked to regional manufacturing capacity. And then if you can get the surge mechanism for funding right in the event that the worst happens and we have to escalate responses, I think we could have a much more equitable response next time round, agreement or no agreement.
Thank you, Helen. And sorry that we did go 10 minutes over. This was, of course, the thing that fundamentally changed the world. It's got a very specific title, How We Prepare for the Next Pandemic, kind of benign. Suman reminded me at coffee this morning that we're kind of still we're in a state of post-traumatic amnesia almost. The scale of it was so significant. But thank you to the panel for a really insightful session. I'm very taken, Arabella, with the notion of keeping on talking. And that's what I encourage us all to do. Environmentalist climate change colleagues have a saying, think global, act local. And I'd like us to do that too. A lot of the lessons that Helen and the rest of the panel have just talked to us about encompasses those elements. We don't need to wait for big agreements. We desperately need those big agreements, but we can't wait. We can act locally, we can act cooperatively, we can act regionally, we can act with a sense of self-reliance, we can act below our governments. People in this room and our networks can act to collaborate, to reach out, to keep talking. That is a much stronger power than you think. And so I'd like to encourage you, and thank you, Arabella, for reminding us of that. Thank you all.